a Deuk laser disc repair surgery, which is to really debride the tear within a herniated disc that's causing back pain and also leg pain. So this patient has 3 discs that are damaged, degenerated, herniated, protruded, many different adjectives, but in the end, all that matters is there's 3 not normal discs that are right in the area where he's having his back pain. He's had back pain for how many years? 15 years? Yeah. 15 years. And he's had leg pain for 1 year. Left leg. We're broadcasting, right?
Correct, yes.
All right, good. Left leg pain times 1 year. And his right leg's fine. So if you look at his MRI, you can see a herniation here at L3-4. L4-5 is pretty collapsed and degenerated, and L5-S1 has a pretty good sized herniation on the left. All right, and there's a small herniation of 4-5 with a bone spur. So he's got disc osteophyte complexes. So we're going to start by gaining access. I've already given him some numbing medicine. I have to get into the L5-S1 disc, which is going to be the hardest part of this surgery, for sure. Sometimes I can't even get into a disc because the disc is too collapsed. So we are going to try to get into L5-S1 here and fix it. Now the alternative surgery here would be a fusion shot to go in and clean out these discs and basically put in cages. Screws and rods. Let's get an AP. I think I'm too medial. The problem with fusion surgery is that it's very invasive, causes damage to the muscles, bleeding, pain, suffering. It's all unnecessary as long as you can fix it with the laser. That looks pretty good. I'm hitting a bone spur right there. So let's see if I can get around this bone spur. Need to be just a little bit more lateral. Shot. Yeah. It's shot. No, 5-1 is not going to be easy. You doing all right over there? We have a guest anesthesiologist today, Dr. Edwards, who's been here many times before. 5-1 is giving me a hard time. A lot of bone spur right there. Let's just check an AP and see where we are. I've tried a more lateral entry point. The beginning of the surgery, we use navigation with the X-ray machine to try to find our way into the disc. Yep. The surgery really begins now with access to the discs that we're trying to repair. And the access is done with spinal needles. This is what we have here. Shot. Yeah. Shot. Shot. Are you awake? All right, I think we've got an orbital. He is. I think we got an orbital. We need to make an orbital correction, maybe 1 degree. So when I'm talking to my X-ray tech, Jordan, and I'm telling him to adjust the fluoroscope, the trajectory, maybe the other way, shot, so that I can have a clearer picture of what's going on here. All right, is he awake?
Yes. Hey, Mr. Campbell, he's awake.
Are you having any pain?
No.
All right, let me know if you do, okay? It's very important.
Says okay.
All right, I think we got a WAG issue now because I'm seeing a double bottom pedicle at 5. We need to correct. Now the patient's doing great. He's not moving. I'm very happy about that. But we need to get our X-ray machine lined up a little bit better. I think that might be better. Again, the problem at 5-1, it's the hardest level to get to, but also he's got a lot of stenosis. Let me know if you feel any pain, okay? He said okay. Sean? So we're right there at the 5-1. I'm just below the nerve root. Sean? And trying to get into that 5-1 disc. Any pain? Huh? This is probably the most important part of the surgery. No pain down your leg? No? All right. And I need my patients awake for this part because they're the most sensitive indicator if I'm too close to a nerve root. Yeah, it looks good right there. So the tip of the needle is exactly at the entry of the disc. It's in the mid-pedicular line between the L5 and S1 pedicles. Let's show the audience the L5, oh, never mind, and S1 pedicles. All right. I can feel the herniation there. Well, we got lucky, I guess. Are you comfy? Let's give them some more local. So the L5-S1 disc needle, lay still, don't lift your head up. Are you okay? Are you uncomfortable at all? I can't hear him.
Yes.
What's uncomfortable?
It hurts. Oh, he's okay.
Oh, he's okay. All right, good. Yeah, just sometimes the shoulder will hurt or their hip will hurt, you know, because they have a hip arthritis or something. And we want to make sure we get them as comfortable as possible. That's why I tell Luis to always position them awake, the patient awake. That way we can get feedback from the patient. Shot. All right, we are in the L5-S1 disc. I think you're off on orbit. You can see a double shadow at the back of the vertebral body superiorly. You're off about 1/2 degree to a degree on orbit. I think it's worse. I'm not sure though. I see it more now. Never mind. I think it's the other way. See that, Sean? It's about 1 degree. That's better. Actually, that's good. That's as good as we're going to get. Let's show the audience the foramen and how narrow it is. Let's show them 3-4. 3-4 foramen. Circle it with the arrow. No, that's not the foramen. Go up. There you go. The foramen is relatively normal, except there's a little bone spur on the back of at the top of the facet right there. Yep, he's pointing to it. But it's not big enough to cause any problems. The real issue here is the herniated disc. Now go down to the next foramen. It's smaller. And again, it's smaller because of arthritis changes. There's bone spurs and thickened ligaments and bulging discs. We're going to go fix the disc. The 5-1 is the narrowest foramen. Okay. We've made our incision. It's 7 millimeters or 1/4 inch. And now I'm headed for the L4-5 disc. The L4-5 disc is pretty collapsed and degenerated. People are always asking me, can you do this for degenerative disc disease? The answer is yes, you can. Is that my latest picture?
That's the latest picture, yes, sir.
All right, shot. So I've got to navigate just lateral to the facet joint, which I'm doing. Shot. And I'm going to head right towards that disc. Any pain?
No.
Huh? No? Good. All right, so I'm at the back of the disc. Let's get an AP. You always want to use 2 views, folks. Side to side, which is called lateral, and front back, which is called AP. AP stands for anterior, posterior in Latin. Looks perfect. It's exactly, show them the mid-pedicular line. So you can see the pedicle of L4. Go up to the left, not the spinous, but yeah, that's the pedicle, circle that. The pedicle of L4, and go to the mid-pedicular point, the middle. Yep, and go straight down to the middle of L5. Show them L5 pedicle, yep, that's the L5 pedicle, circle it. Yep, and go to the middle of that. So a straight line between the middle of the pedicle of 4 and 5 is where the disc begins, and that's right where the needle tip is. So it's perfect positioning. Lateral view. So far, so good, folks. You have to use good quality imaging in the operating room. It's called medical imaging. We use a fluoroscope. We use the very best that money can buy. It's a very expensive unit, but it's worth it because it gives you the best pictures. All right. Unfortunately, Siemens has gotten into the habit of making their units obsolete so that we have to buy new ones. And people always wonder, why is healthcare so expensive? Well, when you pay $160,000 for an x-ray machine like this one, and it costs Siemens probably maybe $20,000 to make it, now you see the problem. The problem is the manufacturers of these equipment and devices and medications, they basically price gouge you, the provider, but the provider is forced to use them because you want good quality. So unfortunately that has to be passed on to the patient. But patients and insurance companies are always wondering, why is it so expensive? It's expensive because we don't settle for using anything less than the best. As a result, we have very good results, the best outcomes. All right, we are right at the back of this disc, and we're literally bumping up against the end plate, which is fine. I'm trying to wiggle my needle in using my needle jockeying techniques, but for now I think we're going to leave it right there, because sometimes when the patient's awake, they kind of tighten their muscles down, and that makes it harder to get in. So we're going to put him to sleep shortly, and then I might try to advance it. We'll try to do the entire surgery, 3 discs through 1 incision. It's pretty standard for us. Sean? It looks like we should be able to get this done. Sean? Are you comfortable still? You're doing great, by the way. Sean? We're going to put you to sleep soon, okay? Now his worst herniations are at this disc, 3-4, Sean, and 5-1. Sean, I'm bumping up against the facet. Sean, going around it. Any pain in your leg? AP. All right, we're just about in position with this 3rd needle. You can see the higher discs in the lumbar spine above the L5-S1. They're a little bit easier to get into because L5-S1 is so challenging. But we were able to get into the L5-S1. I think we're going to verify that in a moment with a discogram. So once we place the needles, the next step will be the discogram. Are you okay?
Yes.
All right, we're going to start our discogram in a moment, so let's keep him wide awake. We want to get his response. Are you comfortable?
Yes.
All right. I'd love to get that 4-5 disc accessed. All right, so you can see from the x-ray, we have accessed the, yeah, I'm right there. We've accessed 3-4. We're sitting right at the back of the disc at 4-5, and we've accessed 5-1, I believe. All right, we got to get a better x-ray picture. Let's move the fluoro south a little bit. And can you drop it anymore? That's too much south. Let's just see where you are. It's just like literally a ½ inch. That's a little too much south. Let's go slightly north, maybe a ½ inch, and just sit it right there. All right, Henry, can you see this x-ray pretty good?
Yep, we can see it.
All right, good. So I always want to make sure the patient's comfortable. Are you comfy? All right. No pain right now? No pain. Very good. Reliable, responsive? How bad is that on a scale of 1 to 10? How high does it go? 9. Is that where you typically get pain?
Yes.
Yes. So we got a 9 out of 10 concordant at 5-1. What that means, folks, is that the L5-S1 disc is causing his pain that he gets every day. That's his typical pain. And he got a 9 out of 10 from that disc. Is that better now?
Yeah.
All right. Did it go away, the pain? Thanks, Luis. Yeah, concordant. So put a C. Concordant means that's the pain that the patient experiences every day. That's the pain we're after. We want to get rid of that pain. Are you better? All right. How bad is that on a scale of 1 to 10? 10. Is that where you get your back pain? All right, so 3-4 is a 10 out of 10. 5-1 is a 9 out of 10. You can actually see the tear in the back of the 3-4 as well. Let's show them the tear, please, and the herniation. Henry, go to the fluoro picture there. You can see that white arrow. There's the tear in the back of the disc. Show them the tear and the herniation. Show the herniation. Yep, there it is. Okay. So the cause of the pain, what we discovered at Deuk Spine Institute, we're the first in the world to discover this, and we published it 10 years ago, is that the tear in the back of the disc, called the posterior annular tear, is the cause of the back pain. Are you comfy? Huh? I couldn't hear him. All right, I don't think we can do a discogram at 4-5 because we need to advance it a little further. So we're not going to be able to do the discogram at 4-5, but we're going to go ahead and proceed. So now we're going to put our patient to sleep. We're going to use something called propofol. When you wake up, your surgery will be done. That pain will be gone. So I want you to count out loud from 1 to 100 for me. Keep counting and don't stop. All right. So the good news is we were able to do our discograms at 3-4 and 5-1. 4-5, I'm at the back of the disc. I need him to be asleep to advance it because he's really tightening his muscles from the pain from the discogram and just getting in there. And that's causing him to tighten the muscles and clamp down on the disc. So I'm unable to get into that 4-5 disc right now, but I will be able to get into it later using the dilator. Keep counting, you're doing great. So I'm having my patient count. That way I know when he falls asleep because he stops counting. And that way our anesthesiologist can gradually put him down and give him just the right amount of sleeping medicine called propofol by monitoring his counting. Keep counting. You're doing great. All right, so it sounds like he's trailed off on the counting. Shot. I got to get the guide wire into the needle. There it is, right at the front of the 5-1 disc. I'm going to remove the needle, leaving the guide wire. And we're going to use this guide wire to go down to the disc and basically repair the disc. Now, the alternative surgery that would work for this patient would be a spinal fusion. But he doesn't want a spinal fusion. Nobody wants a spinal fusion. Spinal fusion, the incision is really this long for this kind of surgery. Big incision, the muscles are going to die. He's going to be in horrible pain as they die off for the next few months. Everybody's in pain after spinal fusions from muscle damage. And it's unavoidable. And you're going to have metal in your back and a stiff back. Of course, then you get adjacent segment disease, which is bad. Shot. So instead of all that, we fix the disc naturally with the Deuk laser disc repair. There's no metal, there's no fusion. We're not even at the hospital, folks. We're doing this outpatient at our surgery center. We've been doing these surgeries here now for 10 years almost, coming up on 10 years. Before that, we were doing them in our office-based center, and we were doing them there for an additional 6 years. So we've been doing these surgeries 16 years now. Shot. So I pulled the guide wire back a little bit. Is he okay, doctor? I'm just going to gently advance the dilator to the back of the disc, and then we're going to go into the disc. This is going to be the stimulating part for him. And we're in. You can feel it. Take the guide wire out, please. Take the guide wire out, please. Shot. All right, we've got our dilator in the 5-1 disc. This is where he's getting, remember, is he okay?
Yeah.
9 out of 10 pain. He's doing great, by the way. You could lighten him up a little bit if you wanted to. You need anybody's help? If you need a nurse back there, we'll be happy to give you one. Shot. Now the tube goes in. Shot. The tube goes down right over the dilator. So the dilator acts as a guide for the tube, but also it allows us to put this tube down without doing a biopsy of the disc. We don't want to biopsy the disc. We want to remove the herniation and we want to clean the tear. Let's go ahead and show our audience why do herniated discs like this with annular tears, why do they cause so much back pain? What's the mechanism? What's the reason?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back. As you can see, we've placed our tube. It's called the tubular retractor. That's what you're looking at, the walls of the inside walls of the tube. And the blue thing is the laser fiber. And it's transmitting laser energy from a machine that's sitting at the patient's feet. And we talked a little bit about costs earlier. The laser itself, machine is around $120,000. So things start to add up quickly. You know, you're getting into the millions and millions of dollars to be able to set up a center like Deuk Spine Institute has done in order to provide the best, most advanced surgery in the world for the spine. None of it is cheap. All right, well, you've watched the video on how do herniated discs, bulging discs, degenerated discs, how do they cause back pain? And now we're here to fix that back pain by cleaning the tear that you saw on the video that causes all the pain through inflammation. And we're inside the tear right now. One of the nice things about this particular surgery is we don't have to damage the rest of the spine in order to fix this herniated disc. What I mean by that is traditional spine surgeries like microdiscectomies, laminectomies, the surgeon is removing normal spine to get down to the part that's narrowed. And the things that are normal that they're damaging is the skin with a big long incision. Then they have to damage the muscle right under the skin that covers the spine because they got to move that over to get to the spine. So they end up damaging the muscle. Then they've got to damage the ligaments in the back of the spine that hold the spine together. They have to remove those. Then they have to remove the lamina, which is nothing wrong with the lamina. Your lamina is normal. Then they have to remove the facet joint, which holds the spine together and stabilizes it. They'd be like removing one of your knees and expecting you to walk normally. Then they have to remove the interspinous ligament, the supraspinous ligament, which holds the spine together. Nothing wrong with those guys either. Then they've got to remove the ligamentum flavum, which is underneath the lamina, but above the nerve. And after they do all of that, then they got to push your nerve over hard, retract it, which can cause damage to the nerve. And finally, they've got to bipolar veins, which means they got to remove veins, which are blood vessels in your spine that are normal. And after that, then they can actually start working on your herniation. So think about that. They had to do so much damage just to get to the part of the spine that actually needs to be fixed. And then they don't even fix it. They literally just take the part of the herniation that's sticking out, they take that out with grabbers, but they leave the tear that's causing all the pain. So that's why we don't do traditional spine surgery here, because it doesn't work. It's not good for patients. We do this procedure because it works much better, it's much safer, and doesn't cause any kind of adjacent segment disease or reherniation, as long as patients follow instructions. I understand our audience is asking questions, which is great. We encourage you to ask questions during this broadcast. This is a live stream. Live meaning you're watching a live surgery right now if you're watching on Tuesday, October 11th, 2022 at just about 10 o'clock Eastern Standard Time. We're streaming live so that people can ask questions during the surgery and they can share the experience with us from beginning to end. We have nothing to hide with our surgeries. We want people to see what's done. Let's take our first question.
Yes, this question comes from Lotan B on YouTube, and they asked, how come this method is not adopted everywhere? And then Brian Johnson responded to that being, because doctors make too much money doing fusions and don't know how to do what Dr. Deuk does.
Well, Brian, you're correct. And Lotan, I'm sorry, but that is the truth. This is a cheaper surgery than a fusion. And the cost of this surgery is about 1/3 of a fusion surgery. The fusion surgery, we used to do these fusions all the time. We would charge around $350,000 for this type of a fusion. The insurance companies would pay about 50%. And by the way, that's a standard charge. We charge the same as the hospitals would charge, even though our surgeries are better than done in the hospital, safer. But the fusion surgery is around, out of pocket is going to be probably, paid for $150,000 for a 3-level lumbar fusion. Okay? So there's more money in fusions. Same thing with artificial discs. There's not as much money in an artificial disc surgery, but there's still a lot more money to be made by the hospital and doctors with artificial disc and fusion than there is with Deuk laser disc repair. So that's one of the most important obstacles doctors have encountered in trying to learn this technology is they're not going to make as much money. They're not going to get paid as much. So they don't want to do something that doesn't pay. And unfortunately, a lot of patients with back pain, they end up going to the pain management doctor because their primary care doctors don't know what to do with them. So they send them to the pain management docs, and the pain management docs end up just doing, shots and procedures that don't really work to get rid of the pain. Because the only way to get rid of the pain is to do surgery on the disc. So there are pain management doctors trying to do surgery now. They're not happy with the money they're making doing shots, and they're making a lot more money doing surgery, even though they're not surgeons. So there's a lot of corruption in this field of spine. You have spine surgeons doing what's best for them, not the patient, and you have pain management doctors doing what's best for them and not the patients. Basically, the patients are treated by our medical system as basically just a paycheck, and the bigger the paycheck, the better. Kind of like winning the lottery. If you're going to win the lottery, why do you want to win $1,000 when you can win $10,000? So that's how patients are being treated in the United States of America and other countries, is the doctors and the hospitals and the companies making the implants, the metal implants, are saying, hey, we want to hit a home run with every patient with how much money we make. That's really what's happened. It's corruption. So I even make a lot more money when I do fusions. But the reality is that this is the future of spine surgery. So the sooner we start adopting it and accepting it and doing it, the better we're going to be at it in the future. And that's why we're establishing ourselves as the world's leader in the endoscopic spine surgery arena, as well as, more importantly, in curing back and neck pain. Because there are surgeons who do endoscopic spine surgery out there in China, Korea, Germany, even the United States, but none of them do what we do here at Deuk Spine. And the difference is they're treating leg pain, only leg pain. We're treating back pain and leg pain. And the reason we're able to treat the back pain is we do an annular debridement. They don't. The annular debridement is unique to the Deuk laser disc repair procedure. So basically, the annular debridement, which is what I spend 90% of my time doing here, is something that we discovered and published 10 years ago in the Deuk laser disc repair publication in Surgical Neurology International. You can look it up on PubMed. And being the first in the world to do an annular debridement, we're the first to be able to cure back pain from a herniated disc. So I don't know what else to tell you except that there's a steep learning curve. It's not easy to do these surgeries. It takes a lot of skill and experience and training. Surgeons aren't really willing to do that. They've already been trained to do fusions in their training program, and that's what they want to do. They want to do the fusions and the artificial discs that they've been trained to do. They're not willing to learn a new technology. I've been trying to teach people through these broadcasts for 10 years now almost. And I have doctors all over the world that watch my surgeries. Many of them adopt what I do and start to do the Deuk laser disc repair elsewhere. I know I have some Indian doctors and Chinese doctors that have been on this broadcast and have watched what we're doing and have started to do what we do. But in the United States of America, I don't know of any other doctors that do what we do. So it's unfortunate for the patients, which is why we do the broadcast, so that the patients can learn the truth. I can't fix the doctors, but I can certainly inform the patients. Today, by the way, we have 4 surgeries. They're all Deuk laser disc repairs of patients that have traveled here for the surgery. This patient, I'm not sure where he comes from. Anybody remember? He's from Oviedo. All right, so he's local, about an hour away. Oviedo is close by. And he's here with his lovely wife, who's going to take him home afterwards. For those of you who don't know, this is an outpatient surgery. We don't keep people in the hospital. As a matter of fact, we're not at a hospital. We're at the surgery center. I would not be able to do this surgery at the hospital simply because the hospitals don't have all this equipment that's necessary to do the surgery. They wouldn't buy it. It's too expensive. They don't want to spend the money on it. And of course, they make a lot more money by doing fusion surgeries or artificial disc surgeries. So why would they want to change their revenue stream and take less money? They don't. Hospitals are businesses too, so they're looking after their financial interests, just like the companies that make the screws and rods are looking after their financial interests. So that's why we broadcast, so that people can learn the truth. Grabber? Great question. Sorry I don't have a happy answer for you, but I have a truthful answer for you. By the way, just so you know, I have taken this procedure overseas. I've taken it all across the United States to meetings, national meetings of neurosurgeons, taught them at the national meeting what we're doing. And how many do you think have contacted me and said, hey, I want to come and do a year fellowship and learn how to do this surgery? Zero. I get a lot of interest from international surgeons, doctors from around the world, but we can't really train them because they don't have a medical license in the United States. So there's only a limited amount they can do. There's a big herniation. Oh yeah, look at this.
All lights
There
on.
it is, light on,
The
show
ceiling,
them.
The ceiling, the ceiling.
I need a blue towel. Can you see this? Right
yes.
there?
Yes, we can see it.
So that is the big herniation. I finally got it. It is ginormous. Look at that thing. Woo! All right. I'd be high-fiving my staff right now.
Okay.
See how nice it is? We do this 1/4-inch incision. It's a Band-Aid. Luis is going to do a closure when I'm done. And this patient's going to walk out of here an hour after his surgery. You don't have to go to the hospital. You don't need narcotics, painkillers afterwards. We don't even prescribe them. There's no Percocets, no Lortabs, no Dilaudid for this surgery. It's literally Tylenol and a muscle relaxer for one night. Most people don't even take their medication, Tylenol or muscle relaxer. Half of the patients take no medications, pain meds after the surgery. Half, 50%. The other 50% take them for usually 1 or 2 days maximum. So this is a pain-free surgery. And you can see there's no bleeding either. Now, what does this surgery fix? This surgery fixes back pain that comes from a herniated disc. That's about 85% of people's back pain. So if you take 100 people out there that have back pain every day, and you say, okay, what's causing their pain? 85% of them, it's coming from a disc problem. Degenerated disc, herniated disc, bulging disc, ruptured disc, prolapsed disc, extruded disc, protruded disc. There's so many different names, but it's all the same thing. It's not the disc itself. I mean, it's the tear in the back of the disc that's the cause of the pain. And that's what we're here right now. This is the tear. I'm cleaning the tear at L5-S1. Now, people want to know, is my MRI going to be normal after this surgery? The answer is no. We're not here to make your MRI look normal. Nobody can make an MRI look normal. If the goal of surgery was to make an MRI look normal, we would never do surgery. Nobody would ever do surgery because you can never make a disc look normal once it's been damaged. That's not our goal. Our goal is to get rid of the symptoms from the disc. And that's what we're going to do here. Do we have any other questions?
Yes, we have 2 so far. This next question comes from Lotan B once more on YouTube, and they ask, how do you find out for sure where the pain is coming from? EMG, MRI?
Great question. How do I find out for sure where the pain's coming from? The answer is you, the patient. Here's why. The pain you're feeling is called localized pain. And localized pain is pain that the patient can localize. What does localization mean? It means you can point to it. That's really the basic, simple answers. You can show me where your pain's coming from. So what I use is your exam, the physical exam. Everybody wants me to tell them what surgery they need based on their MRI report, but I can't do that because a lot of people have damaged discs that don't cause symptoms. We don't treat them. We don't treat those discs that don't cause symptoms. We only treat discs that are damaged that cause symptoms. So I use a combination of the patient's exam with the MRI to determine where their pain's coming from. By the way, since you've been here last, Dr. Edwards,
Yes.
we started putting a little Novocaine in the discogram material, you know, to numb up the disc while we operate on it.
Before the methylene blue or after?
What's that?
Before the blue or after?
No, it's in the blue. It's in there. It's in this the injectate.
Does that compromise your pain level?
Yeah. Thank you. What's that?
Does that compromise the response to the pain level when injected?
No. No, because it takes time for it to set in. And we're getting an immediate response.
Sure.
Yeah. Yeah, we're getting it literally as I inject. The pressurization of the painful disc gives me the discogram response. So
How much do you use?
we're using about, what, 3 cc's, Luis?
6.
6?
cc's of what? In 50 cc's of 6 cc's of lidocaine. Marking.
Yeah, so it's
So
a,
that takes, yeah, the onset.
it takes a few minutes. But by the time we get to the disc with doing this procedure, it's set in. Yeah, so Berndez really has been advocating for that, and I think it makes a big difference. He said he can see the heart rate of the patient is more stable now that we've been doing that procedure. What we're talking about, folks, is evolution of the process of Deuk laser disc repair. Most specifically, we're giving a little bit of numbing medicine during the discogram. So the numbing medicine takes a few minutes to set in, so it doesn't affect the discogram results. We get an accurate result, but what happens is when I get in here, like right now, when I'm starting to use a laser, the nerve endings are a bit numb, so it doesn't hurt the patient as much to do this. And what that means is that the anesthesiologist doesn't have to use as much propofol sedation, which is better for the patient. It's safer for the patient. All right, we're done with this level. Laser off. Let's see if we can see the nerve root. The nerve root's right up there in that fat. You can't really see the dura covering, but that's where the herniation was. That's where the annular tear is, and that's what needs to seal up over the next few months. All right, let's go ahead and show the video of how does the Deuk laser disc repair actually work. What are we doing in there with that laser? Meanwhile, I'm going to give a little antiseptic to cleanse the wound. We use betadine, developed by NASA, just a few miles away from here. We're in the Space Coast of Florida, right next to NASA and SpaceX, where they launch satellites into the space. We're just cleaning out the antiseptic there. We also use IV antibiotics for patients that are not allergic to antibiotics. So we're using several different techniques to prevent any infections from happening. We use a special paint on the skin. We use a special sticky material that's impregnated with iodine to kill any bacteria. We do the IV antibiotic. We use sterile irrigation, and lay still. You're doing great.
The cables run down here. And you put it
Yeah, just put them there. And then, of course, we do the antiseptic at the end, the betadine. Now we finished the L5-S1 disc. We're going to move on to the L4-5 next, or the L3-4 next. Maybe the L3-4. And then we're going to do the L4-5 last. Just put pressure here. I'll do that if you want. Thanks. So we're going to hold pressure on the muscle because muscles can sometimes ooze a little bit of bleeding, and by putting pressure it stops that. It takes about 3 to 4 minutes for a normal human being to stop to clot off, or if there's any torn little veins or capillaries. And we put pressure during that time. Alrighty. Shot. Alright. So we're going into the 3-4 disc shot. I've got to make sure the guide wire is in the disc. I want to see it on my lateral view. I feel like it's up against the end plate of 3. Relax a little, Luis. Alright. Taking my needle out. You've got to be careful when you take your needle off the guide wire that you don't pull the guide wire out. I actually hold the guide wire in one hand and I hold the needle in the other, because if you pull your guide wire out, well, you're going to be in trouble. Shot? And what I mean by that is you're going to have to start over again by putting the needle back in. And I would recommend doing that with a patient awake to make sure you don't get too close to a nerve root while you're doing it. All right, we are going down with the dilator. Shot. Want to keep an eye on my guide wire, make sure it doesn't come out of the disc. That guide wire is providing a path of safety. Oh, we're not back yet, are we?
No, we never went to commercial.
All right, yeah, let's go ahead and run our video of what does the Deuk laser disc repair actually do.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Okay, welcome back. Now you understand what it is we're doing here endoscopically with the Deuk laser disc repair procedure. We're actually going to do the whole surgery through this metal tube. It looks like a metal straw, but it's actually called a tubular retractor. It slides over the dilator and creates the pathway or passageway to do the surgery. So it's a retractor. Now, some people say, was this percutaneous? The answer is no. Percutaneous procedures are procedures done through needles. This is not a needle-based surgery. This is an actual real endoscopic surgery. Now, the Deuk laser disc repair surgery, we've published it many times in the medical literature, as well as at national meetings where I've given talks on how to do it overseas in Hong Kong, throughout the United States, at the American Association of Neurological Surgeon meetings, Congress of Neurosurgeons, spine section. And despite all those talks and all that teaching, again, the adoption of the technology is minimal to none. And the reason is, I'm telling you, it's number one, no surgeons want to stop their practice for a year and come learn how to do this. Also, they don't want to give up the money. There's so much infestation of our residency training programs by implant companies trying to sell screws and rods and metal plates and cages successfully, by the way. They're getting in there and they're basically bribing the director of the program with millions of dollars in support for research and whatever else they want to do, parties. Meanwhile, through those bribes, patients are suffering because they're not getting less invasive treatments that don't require metal. To get the money from the metal companies, you got to put metal in. That's the trade-off. And it's unfortunate that that is the case, but it is. I can't fix that. It's a corrupt system. I don't know why our government doesn't do something more about it. They tried for years. They went after surgeons that were taking bribes to put metal in. They still are. But those guys have kind of covered it up in a different way now. And what they're doing is those metal companies are basically paying departments of neurosurgery or orthopedic surgery millions of dollars a year in consulting fees to their head of spine surgery, who then makes the residents do fusions and artificial discs. And so it's a system where the top guy is getting all the money, bribes, and forcing all the little guys underneath, and gals, to do these invasive surgeries. So of course, by the time these doctors come out of training in the United States or around the world, they've been indoctrinated in metal. And that's what they offer patients more than ever before. I used to be a surgeon who did a lot of metal. You can go back and look at my surgeries. I've been doing more advanced fusions than anyone in the country, in the world, because my fusion patients go home a few hours after their surgery. Nobody else has been able to do that. And that's despite them having multi-level surgeries, fusions with osteotomies and interbody cage, interbody fusion, reconstruction of the spine to correct deformities like scoliosis, kyphosis, listhesis. So I did all those major surgeries on people that were even old people, 80, 90 years old. Got rid of their pain, got them out of here in 2 to 3 hours, home. So I was a top metal fusion surgeon in the United States, and I started doing more of the laser surgery, and people just demanded it. So I've gotten away from fusions. I think this is a much better surgery for people. And the problem is that my colleagues have not followed suit. So really we need the consumer, the patients, to demand better surgery from their surgeons. But the patients won't know about better surgery because their surgeons won't tell them about it. So they're being lied to, lie of omission. And that's why we broadcast, really, so we can teach people that there is a safer, less invasive, non-metal surgeries that work better than the metal surgeries do and don't have the complications or side effects. But getting the message out is hard. You know, there's a lot of people who don't understand what we're trying to do here, and there'll always be haters. I get it. I know that's true, but that's not going to stop us from teaching. So we'll take any questions that are out there. Just so you understand, take a look at this. It's pretty cool before you start. That's the end plate. The pink thing over there is the bone of the vertebral body below, and then that's the one above. This is the annular tear. Look at the pink coloration. That is all inflammation tissue. I just showed you the video of it. I even made it pink on the video for you. And that's it. That's where all the pain comes from. So if we annihilate this tissue, get rid of it, obliterate it, vaporize it, then we get rid of the source of back pain. Same thing in the neck. For herniated disc in the cervical spine, we can get rid of neck pain. We can also get rid of thoracic pain. So it doesn't matter where the disc is in the body. If it has a tear in the back with that inflammation going on, it's going to cause you pain, and we can fix it with the Deuk laser disc repair. All right, stand by. We'll take those questions.
Okay, this next question comes from Angelo Rivera on YouTube. And they ask,
Hi, Angela.
They ask, when do you decide that you removed enough herniation before going too far?
Basically, when do I decide I've taken enough herniation out? I take as much as I can safely get. And what I'm limited by is the technique. But it's still more than you get through any other technique. I would estimate that we get rid of about 80% of the herniation on average. And that 80% is enough to get rid of 100% of the symptoms, most of the cases. Our average elimination of pain is 98% with this technique. Now, understand something is very important. This surgery fixes herniated disc problems. It doesn't fix sacroiliac joint, facet joint pain. It doesn't fix piriformis muscle tears. So there's other causes of lower back, or actually pelvic pain. It's really pelvic pain that people get from the SI joint inflammation and from torn muscles in their buttock. This doesn't fix that. So some people have both. They have a herniated disc causing pain or degenerated disc causing pain, and that's what we can fix with this technique. I don't know. Everything in the tear I debride, I get about 80% on average, and it works. I haven't had a single patient that has persistent disc pain after this surgery. I have patients who have pain after the surgery in their pelvic area or their back, but it's not coming from the disc that we just fixed. It's coming from facet joints. It's coming from other muscles or joints that were not treated with the surgery. And we can fix those too. They don't require surgery usually. I don't know if that answers your question.
We have a couple more questions.
Yeah, happy to take your questions, by the way. Type them up, ask away. We've got one more disc to fix after this one, and then we're going to be done with the surgery. We've got a few more surgeries today that are all Deuk laser disc repairs.
All right, this next question comes from Lotan B once more on YouTube, and I'm confused with the first part. It says, like new disc after surgery, or it's very sensitive to new herniation. And the next question was, does it fix neurological symptoms?
Yeah, great question. So does it fix neurological symptoms with this surgery? The answer is yes, if your neurological symptoms are fixable. What that means is if you have a pinched nerve that has damage that's permanent because you waited too long to get it fixed, this will not fix permanent damage. But if you have a pinched nerve that can be unpinched and the symptoms go away, then yes, this fixes neurological symptoms from the pinched nerve as well as from a pinched spinal cord in the neck if you're having cervical done. As far as, I can't remember the first question. I couldn't really understand what they were asking.
I believe it's, is it very sensitive to a new herniation after
Yes.
the surgery?
So the question is, when I'm done with this laser surgery, can you get a second herniation through the same place? The answer is yes, you can. And it is possible to do that until your disc heals totally. It takes 1 year for the disc to totally heal, where you won't get another herniation. And if you re-herniate in that first year after the surgery, then you got another herniation, another tear that's not going to heal, and you're at risk for it getting worse. So we give people restrictions of their activities: no bending at the waist, no lifting anything over 25 pounds for the first 6 weeks, and then it goes to no bending at the waist and no lifting over 40 pounds for the next 6 weeks, and then it goes to no lifting over 40 pounds till the end of the first year. So it's really a lifting restriction and a bending restriction. As long as you follow those restrictions, the chance of re-herniating is almost zero. The only patients that have re-herniated are the ones that really don't follow the instructions. I've had a couple of patients re-herniate cervical discs at night while they're sleeping. They sleep without their collar. They can actually torque their neck in their sleep and re-herniate. So I always tell people to sleep with their collar if they're having a cervical disc fixed. All right, we're just about done with this herniation here at L3-4. And that's a little bit of fat right there, or a blood vessel. I'm going to try to leave it alone, just work underneath it. I think there's a little more that needs to be done right here, and we're pretty much done at this disc. Then I'm going to go to the next disc. Everything okay, guys? Yeah. All right. I'm going to go to the next disc, which is the L4-5. So this whole area you're seeing, this open area, the gap, that's going to fill in with collagen. Everyone's talking about collagen these days as a healing agent, anti-aging agent. Collagen is made by your body naturally to heal injuries. And it turns out that these discs that we're working on, they're actually, the outer wall is made from collagen. So fixing them is quite easy. Your body is able to repair them quite easily once you clean out the herniated part. We're pretty much done here. Make sure there's no more pieces of herniation in there. Hold the tube. Okay. Just trying to get out any loose pieces, and I don't feel anymore, see anymore. I think we're good.
All right,
Yeah.
eyes on, please.
Scope out.
please.
So we're done with the L3-4. We're done with the L5-S1. Now we just have one more disc to fix, and it's the least infected of all of them, but still in his pain zone. What other questions do we have from our audience? Great questions so far, by the way.
Yes, we have another question from a question from Running Myself Raw on YouTube, and they asked, "Does insurance cover this procedure?"
Yeah, great question. So does insurance cover the Deuk laser disc repair? The answer is yes, most insurances do. It doesn't mean they're going to pay right away. We may have to put up a fight and try to get them to pay. The insurances that don't cover it right now include Medicare, Medicaid. We do get a lot of work comp that covers it, and You okay?
Yeah.
And certain insurances cover it regularly without giving us a hard time. Other insurances, we have to appeal and fight them to get them to pay. So it just depends on your insurance. But that said, typically what we do is we take a deposit from the patient before they have surgery, and that deposit then is applied towards what they owe, total charge. We bill the insurance company the total charge, and if the insurance company pays the full bill, then the patients often will get some of their money back as up to the amount that the insurance company says they have an out-of-pocket responsibility for. So we've had all the major insurances pay for it from time to time. And like I said, because we don't have a contract here with the insurances, usually we don't know what they're going to pay. So because we don't know what they're going to pay, we have to take some money up front from most every patient. Shot? We can't take the full risk of the bill not being paid and then having to fight the insurances for 3, 4, or 5 years and sue them. All right. There's, when you ask if insurance covers things, if you go to the doctor, does your insurance cover it? Well, you could say yes, but then you still have to pay a copay, a deductible, and coinsurance. If you go to the pharmacy, you still have to pay a certain amount of copay for your medications. If you go get an MRI, there's deductibles. A lot of people have to pay $500 or $1,000 for their MRI, even though it's quote-unquote covered. So coverage really is a loose definition. There's no hard definition of coverage. And the out-of-pocket responsibility is really depends on what you're getting done, as well as whether there's a contract in place between you and the payer or the payer and the facility. So there's a lot of variables. And unfortunately these days, a lot of insurance companies have found that it's very profitable to not pay providers like hospitals and doctors, because a lot of the times that unpaid money never gets collected and the insurance company gets to keep it. And at the end of the year, it adds to their bottom line profit. Well, that's not right to do that. And that's why there's hospitals going bankrupt and there's doctors going out of business. These insurance companies don't pay their bills. So just like any other business, you have to be paid for your supplies, your work. Anybody here working for free? Raise your hand. Nope, no hands were raised, except me. I work for free a lot. I don't mind it. I enjoy what I do. But, medical supplies are very expensive, as we pointed out earlier, right? Did you say you're working for free? No. Oh, darn. No. I thought you were volunteering. No. I was excited. I'm like, yes. All right, so far, so good. We're making some progress. Hold on. I think we can take it out now. Yep. Yep. So this is the L4-5. This is the one we've been struggling to get into. And I think we're finally in. This was a tough one. All right, we're in the disc. Now, because the disc is so degenerated and collapsed, there's not going to be a whole lot to take out. We're going to take very little out, but it's strategic. We're going for the tear, the annular tear in the back of that disc. I think that's good right there. This will be the last disc we're fixing. We've already fixed the one above and the one below. We've got one more to do, and then we're done with the surgery. We'll move on to the next case. So go ahead and type up your questions for me, and I'll answer them. Do we have any questions right now?
Yes. We have 2 questions. And both of them come from Assad on YouTube.
Hi, Assad.
And they asked, first question, hello, Doc, and may I ask how how's MZU?
All right, let's see. Let me better understand the question. What was the first part?
Yeah, it just says, hello, doc, and may I ask, how's MZU? And
NCU.
yeah,
I'm not sure what NCU is.
I don't believe that either.
Maybe you can clarify what is NCU. It's probably something I know, but I'm just drawing a blank right now.
So the-
ICU? NCU?
MZU, like Mary Zebra Umbrella.
I have no idea what MZU is.
Yeah.
I'm sorry. I need the scope on. Oh, look at that. Whoa, that's inflamed. Look at all that redness. There's a lot of inflammation going on in here, folks. All right, I'm sorry. I can't answer that question because I don't know what that stands for. But if you want to spell it out, that's great.
No worries. And for his next question, he said, hello, everyone. Great job, doc. May I ask, how much does such an intervention cost for those who do not have an insurance cover?
Yeah, great question. So to answer your question, how much does the surgery cost? It all depends on how many discs are we fixing, how many sides are we going on. For example, this patient has 3 discs, and we're going only on the left side. Some people need left and right because they have pain down both legs. And then, of course, where are the discs located? Are they cervical, thoracic, or lumbar? Cervical disc laser surgery costs different than thoracic and lumbar. Pretty much the lumbars are all the same, and the cervicals are all the same, and the thoracics are all the same. But they're all different from each other. Where's my pedal? All right. So I can't give you a price without knowing exactly what needs to be done. And to know exactly what needs to be done, I would recommend you do what's called a free MRI review to see if you're a candidate for the surgery. Once we've done the MRI review with you, and we use a Zoom link to do it, we're going to do a nice little interview for about 10 minutes. I'm going to get to know where is your pain coming from during that interview, and I'm going to look at your MRI at the same time to verify the source of pain is the disc. When I figure out which discs you need operated on and which sides, then we can give you a price. That's how we do it for everybody, and that's free. There's no charge for that process. But you do have to use our free MRI review link, which Henry will publish right now for you to use. If you know somebody who wants to find out what it would cost to fix them, or if it's possible to fix them, we're happy to do that. We don't charge for that service. And by the way, I do those myself for free. I don't charge for it. So you get a free consultation with a neurosurgeon who does spine surgery exclusively and fixes back and neck pain all the time. You can find out what's wrong and what needs to be done to fix it. All right, we're just about done, Doc. We need about 5 minutes. I'm telling my anesthesiologist that we need about 5 more minutes. That way he can start planning with the sedation of the patient to start waking the patient up gradually. By the way, you've done a stellar job with this. I mean, whatever you're doing, it's amazing. Patient's comfortable, safe. I'm able to not have a moving target. So thank you. Any questions right now for us?
No current questions.
Did we ever get clarification of what was meant by that?
Yes, Assad said, lol, I was typing how much does that cost, but the text just got sent. Yeah, it was a typo.
Oh, okay.
Yeah.
All right. Yep, anybody interested in this state-of-the-art procedure, please fill out the free MRI review form. Let us know you're interested, and we'll do a Zoom meeting. I'll review your MRI at the same time. I'll figure out are you even a candidate for this procedure? Which, you know, most people are. And then we can price it out, what would it cost? Any other questions?
No current questions.
All right, I'll be done in about 2 minutes. Then I'm going to go see the next patient and do their pre-op assessment. Stand by. It's a piece of herniation right there I want to get. It's lateral. Luis, you got to get all the disc out of this thing.
Okay.
There's still some in there. That's looking pretty good. Take that. Just about done, folks. So feel free to type up your questions for me. I'll come answer them for you face to face in our broadcast room in just a few minutes. But we are just about done. We're 30 seconds away from being done here. And I'm very happy with the results. Why are there bubbles? Oh. Yeah, switch it. Well, you know, wait a second. This is my last thing I got to do right here. I just got to get this last piece out. And there we go. So I think we're good. We don't need any more.
All right, eyes on, please. Thank you.
Thank you. All right, folks. Well, we did 3 discs. We saved this patient from a horrible fusion surgery, which they would be recovering for months on powerful narcotic opioid painkillers. And instead, he's had the whole surgery done with 1/4 inch incision. This is the future of spine surgery. Unfortunately, you're only going to find it in a few places right now because, like I said before, doctors and hospitals are making way too much money doing more invasive surgeries. They're not going to adopt this technology without a huge fight. I have to fight the companies that make screws and rods. They have billions and billions of dollars. I don't. So we do this through a grassroots educational process. We show you the surgeries live, answer your questions, and hopefully change the world one person at a time. All right, let me show you this incision. Can you see this down here, Henry?
Yes.
The whole surgery was done with this one little cut, 1/4 inch right there. This patient's going to go home in about an hour, and by tomorrow he'll realize that his back pain he's had for 15 years, leg pain for 1 year, is going to be gone. And we'll probably get a testimonial, I imagine, from him tomorrow. And you'll be able to share his story, his experience, like so many of our testimonials. Why don't you put a link to our testimonial page in the dialog box for the Deuk laser disc repair lumbar on our YouTube channel? Folks, if you're interested in finding out how some of these patients do, we've done testimonials, nice video testimonials, high quality, good information. Henry's done the best ones we've ever made. And Henry will put a link to those testimonials so you can watch and learn. Also, if you go to our YouTube channel, you can actually watch these surgeries. We broadcast them every week from beginning to end live with commentary and questions and answers during the surgery. So you guys can watch and learn. We have literally hundreds and hundreds and hundreds. We have thousands of surgeries online right now on YouTube. That includes all the fusion surgeries too. All right, we're done. Why don't you also run the comparison between the Deuk laser disc repair and a lumbar fusion, which would be an alternative procedure.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
Welcome. I'm Dr. Deuk Majan. I was just with you in the operating room here at Deuk Spine Institute and the Surgery Center of Viera. Our patient is now being woken up and he's going to go recover for 1 hour and then go home. Of course, because he's had anesthesia, he won't be able to drive himself home. He'll have a ride with his lovely wife. Our surgery went well. I was very pleased overall. I was able to get to the L5-S1 disc, and just to give you an idea of how difficult L5-S1 really is, I'm going to use a model to show you. I've done this before, and my teaching aids are here. So the lumbar spine, which is what we are operating on today, has 5 vertebrae and 5 discs. And the bottom disc is the L5-S1 disc. It is the second most common disc to cause back pain or sciatica, leg pain. And to get to it, there's something unique about it. We go through the back and we have to come from the side. But what's unique is this bone right here. It's called the iliac crest, and it really does block access to that disc. You can see the other discs like the L4-5, we come above the iliac crest. We've got clearance there to get into the herniation. But the L5-S1 presents unique challenges in that some people have a high iliac crest you can't get through, so it makes it really hard to get down there to the L5-S1 disc. But we were successful at doing it. You know, it's impossible to tell if I can get to the L5-S1 before surgery. It's only possible during surgery, and for several reasons. One, positioning of the patient. Number 2, the patient's asleep or relaxed, and so they're not moving around. I'm able to try to target it. And then, of course, we're in there with the actual needle going into that disc. Now, what's unique about the Deuk laser disc repair, besides the fact that it just treats the annular tear and the herniation, it's the only surgery to do that, is that with other types of spine surgery, the surgeon has to remove muscles that are in the back of the spine by peeling them off the spine. That causes permanent damage to those muscles. No matter how careful you are, you're gonna kill muscles. The Deuk laser disc repair doesn't damage muscles. We pass around the side of the muscle and go right through between the planes of the muscle and go right into the herniation directly. We also don't remove any bones or ligaments with the Deuk laser disc repair. We go around the spine. We go through a natural hole that's already there to get to the annular tear and the herniation, which is right there in the back of the disc. Very easy to get to endoscopically. On the other hand, if you're doing fusions and stuff, you have to remove ligaments and bones, which is very destructive. So we don't recommend those procedures like microdiscectomy. They're very damaging and destructive. And you may get temporary relief with the microdiscectomy, but you'll be back again, because when the surgeon has to make holes in your spine to get down to take the herniation out, they're going to cause instability of your spine. It's just a matter of time before you get back pain, before you get leg pain, you get a recurrent disc herniation. And then you're going to need a fusion surgery usually done. We don't recommend microdiscectomy anymore. It's an old technique. It's very damaging and invasive, and it doesn't work well at all. Microdiscectomy doesn't treat back pain, it only treats leg pain, sciatica. Now, many people have back pain when they have a disc problem, and we don't want to leave the back pain there, but other doctors seem to think it's okay. They just send their patient to pain management afterwards. And then you're stuck with back pain the rest of your life, and you're getting shots every couple of months, injections and spinal cord stimulators and morphine pumps, and none of it really works. So you just live in pain the rest of your life. You don't have to live in pain the rest of your life. You choose the right surgery in the beginning, the Deuk laser disc repair, and you will not be in pain. Give me 1 second. Exit stage right. All right, we're going to jump to our questions from our audience. Like I said, the surgery went very well. Our patient will be discharged in about an hour.
Awesome. This next question comes from Shaliz on YouTube, and they asked, I'm really hoping this is the miracle I've been praying for. If it is, how long out are you on surgeries?
So Shaliz is asking, how long are you out after the surgery? The answer is 1 hour. You could go back to work the next day. However, you will have some restrictions. The restrictions are with bending at the waist and with carrying things. More than 25 pounds is restricted. So basically, if you have a desk job or light duty job, you're able to go back to work the next day if you want to. Some of our patients want to go back to work the next day because they're providing for their families and they need the paycheck. That's fine, as long as they're not bending over and as long as they're not carrying over 25 pounds in their job. So there are a lot of jobs that people can go back to that don't require bending at the waist or lifting more than 25 pounds. I don't know what your job is, Shaliz, but hopefully it's something that you can get back to work very quickly. Now, because the disc itself doesn't have really good blood supply to the center of the disc, it does take time for these discs to heal. As a matter of fact, the disc is one of the few tissues in the human body, especially the inside of the disc, that has no blood supply. So it heals through diffusion. Diffusion is a slow transport of nutrients from an area that has a higher concentration of those nutrients, which is the outer periphery of the disc, where there is blood vessels, to the center of the disc where it needs to heal. That diffusion process is very slow, and it literally takes months, if not a year, to fully heal. We tell our patients, wait a full year till your 12-year anniversary before you do anything strenuous. That includes working out. For example, if you want to go to the gym after the surgery, you're welcome to, but we request that you don't lift anything more than 25 pounds. So you're able to do low impact, high reps in the gym. Basically, instead of doing very heavy weights, you're going to be doing lighter weights. You're just going to do more reps.
Awesome. And then last question comes from Lotan B on YouTube, and they ask, is cervical more expensive than others?
Lotan B is asking, is the cervical Deuk laser disc repair more expensive than others? The answer is yes, it's more expensive for cervical Deuk laser disc repair than lumbar, but thoracic is the most expensive of all. And the differences are I don't know exactly the numbers, but they're in the order of thousands, usually a few $1,000s, maybe 2 or 3 or 4. I'm not really sure, but it's not like tens of thousands of dollars. So it's a few $1,000s. All right, well, I appreciate you guys being here and watching, and we'll be back again in about 30 to 45 minutes for another surgery. The next surgery we're going to be doing is a Deuk laser disc repair on a lady who's got back pain at L3-4, L4-5 from herniated discs and stenosis causing pinched nerves on the left side. So we're going to do 2 discs. We're also going to be doing the Deuk plasma rhizotomy on her. because she has facet joint pain as well. We're not ready to broadcast that Deuk plasma rhizotomy part, so we'll just be offline for that part, but we'll broadcast the Deuk laser disc repair. All right. Well, thanks for your participation. We'll be back shortly with another surgery, and then possibly two